Hello. So today we're going to talk about um, PNHP's evolving approach to actually winning single-payer healthcare, and what that means and what we're doing to maybe go even beyond that. So we'll talk about both our approach to that, and we'll talk about um, how the organization itself is evolving to be more aligned with that. So to start, I thought maybe I would talk a little bit about how we got here, and where we're coming from. So as you probably know, PNHP was essentially founded in 1987 as a research and education organization when nobody knew what the phrase single payer meant. There was controversy about whether we were fighting for single payer or Medicare for all. The whole the whole landscape was just beginning to emerge, and I think PNHP did a lot to make it happen. In particular, I wasn't active at the time, but when PNHP's co-founders, largely David Himmelstein and Steffi Wohlhandler, really published what was then called the Physician's Proposal for Healthcare Reform or something of that sort. And it laid out a lot of what we're still envisioning as sort of the approach, or the goal, the end state. But that was what started it. A lot of the members who noticed PNHP were first became aware of it because of the publication of that physician's proposal, which was entirely focused on national health insurance. Oop, I lost my slides. We come back. Okay. That's where we started. And that's where we were as an organization, was focused on research and education, trying to get the country aware of what we were talking about, with a heavy focus almost exclusively on physicians, because we thought we needed to, that was the body that we wanted to organize. And then the landscape of healthcare reform changed several times over the intervening period, which I'm going to skip over. But in 2016, from a single payer perspective, it changed a lot when Bernie Sanders raised the mantle and made this a topic that became of national attention. I don't think the organization adapted immediately to that. It took us 2 or 3 years, and then we decided as an organization that the landscape is really quite different. People in the late 2010s, we're seeing articles in the news media about Medicare for all and about single payer above the fold in the newspaper. It was a topic of discussion. We came to the decision that just focusing on research and education, which was perfect for the first 20 some years of the organization, was really no longer, 30 years, I guess, was really no longer adequate, and that the country was ready, and our organization needed to get ready for doing more than that. So we began a process of strategic planning, which included a SWOT analysis, strengths, weaknesses, opportunities, and threats. And we talked to all of our allied organizations, and we had a lot of soul searching about what should we do? Should we remain really just, if you publish it, they will come, which was sort of our heavy, our lion's share of our strategy, or do we need to do more than that? And we came to the conclusion that we should do more than that, and that we would help. So we embarked on a number of projects that were really quite different from what we had done before. The first was in 2020, what we called the Kitchen Table Campaign. We produced a series of campaigns, I think 6 or 8, over the course of about 15 months, a series of campaigns that were specific campaigns. So we looked at, what do people talk about? What do people talk about at their kitchen table? They talk about the unaffordability of care. They talk about pharma. They talk about racism. They talk about COVID. They talk about reproductive justice. So we were so eager to have these campaigns that uh, we created a whole series of these over the course of 15 months, that changed topics every 3 months. We were expecting our chapters to be thrilled to see a topic that they could discuss, that they would have all the tools on, that we would give them videos and present and PowerPoint decks and draft op-eds and all these things. And we were expecting our chapters to sort of hop right in and have chapter meetings on each of these topics that would change topic every 3 months, building to how each one of those links to single payer. And we developed skills as an organization we didn't have. We developed skills at producing those brief videos, at producing PowerPoints, and at producing videos and social media presences. But we realized that that was ridiculous to expect people to change topics every 3 months. So we developed these skills, but they were too diverse in terms of how we did a campaign. And instead, when we heard about this thing called direct contracting, we decided, holy cow, that's where we need to have a major campaign on. So I don't know if you've run into this yet, but direct contracting was a new initiative by Medicare to introduce financial intermediaries into traditional Medicare. It was to actually privatize essentially traditional Medicare. And we were horrified by that. It was a sleeper campaign that the Medicare Innovation Center was producing, and we decided to raise the alarm for that. So for a couple of years, that was what our thrust was on. We took those skills we developed from the kitchen table campaign and applied them to this direct contracting piece and had some pretty dramatic success, I think you could say. The program changed dramatically as a result of our work on this. Our allies were eager to engage with us. It was terrific. And indeed, the DCE campaign, the direct contracting entity program, no longer exists. And it got canceled and it got rebranded basically as ACO Reach. So turns out that's not as much different from DCE as we were hoping it would be, but it's still alive within Medicare, but it's going to end in next year. So we made quite a bit of an impact on this. But then we realized that, hooray, success on that. But the real monster facing Medicare in our mind is the privatization of Medicare. And indeed, we thought Medicare Advantage was the poster child for the privatization of Medicare. And indeed, now, as you know, it's more than 50% of Medicare, and that's been a big part of our focus is on privatization of Medicare, and in particular on Medicare Advantage. So we're not going to talk about the content of that today. We're talking more about the campaign and the process. And indeed, we spent 2 years focused pretty heavily on Medicare Advantage, which we are still, as you know, focused pretty heavily on. And we, during that work, developed this strategic plan that we call the Triple Aim. I don't think anybody's talked about that directly with you, have they? So good. Then that's what we're talking about today. So we've developed this thing called the Triple Aim, and of course, our core mission remains single payer. That's what PNHP was founded for, as I just walked you through, and that's of our Triple Aim. That's one of the three, and we took that phrase Triple Aim from the Institute for Healthcare Improvement. It has a different Triple Aim, and we blithely stole their language with their blessing. But so part one is still, of course, single payer is our mission. But we added these other two pieces to it. So ending profiteering and improving traditional Medicare are the three legs of it. Ending profiteering, we still think that Medicare Advantage is the poster child for profiteering, in particular in this. But we will show you how that's been evolving lately too. And then if we did that, if we succeeded at really sort of disrupting the Medicare Advantage business model and our goal of ending that part of profiteering were to come to pass, well, there's a lot of folks that are in Medicare Advantage today because it's all that they can afford, as I know you have heard me and others speak to. So we need to do more than just that. Hand in hand, we need to be improving traditional Medicare. So we can't focus just on ending profiteering. We need to simultaneously focus on improving traditional Medicare. In particular, the reason people can't afford anything other than Medicare Advantage is because, as you know, traditional Medicare has this dramatic 20% outpatient coinsurance with no limit, a dramatic $1,600 or so deductible before it pays for any hospitalizations, limited to 3 per year. But in order to not be exposed to bankruptcy, 90% of people in traditional Medicare purchase Medigap, which largely eliminates the out-of-pocket maximum, which largely eliminates the cost sharing and eliminates the 20% coinsurance and eliminates the hospital deductibles for the most part. So they need Medigap, but a lot of people can't afford to buy Medigap because it's about $200 a month, which is a lot of money. And then you got to buy Part D, which is another, got to buy a drug benefit for, let's say, $50 a month. So you have to come up with, let's say, $3,000 a year if you want to be in traditional Medicare, and that's cost prohibitive. So they go into Medicare Advantage with all of the problems that you're familiar with. So if we just attack Medicare Advantage without doing something to improve traditional Medicare, we would frankly be hurting people. So our third leg of our strategy is improving traditional Medicare. Number one, two, and three is by introducing an out-of-pocket maximum, ideally eliminate cost sharing in traditional Medicare, but at a minimum, put in an out-of-pocket maximum that matches the current out-of-pocket maximum that's actually in Medicare Advantage. So, as you know, Medicare Advantage has a statutory out-of-pocket maximum of $13,000 or so in and out of network. But in reality, most Medicare Advantage plans sell on average a policy that has about a $5,000 out-of-pocket maximum. So we're proposing at least introducing a $5,000 out-of-pocket maximum so that traditional Medicare is at parity actuarially with Medicare Advantage, but we'd like it to be even lower than that, of course. So number one on improving traditional Medicare is an out-of-pocket maximum. Number two is adding hearing, vision, dentistry, and pharmacy. Um, the trick to that is adding hearing, vision, and dentistry. If you don't do it carefully, you would wind up adding, here's the risk of adding hearing, vision, and dentistry strategically. If you add hearing, vision, and dentistry into traditional Medicare, you're going to be adding it into Medicare Advantage as well, although they already have it. But then they would no longer have to pay for it out of their benchmarks would have to be adjusted accordingly, or they'd wind up getting paid enough to pay for hearing, vision, and dentistry as they do today, and the benchmark would be adjusted to pay for hearing, vision, and dentistry. So Medicare Advantage companies could be getting a win if you don't do it carefully and adjust the benchmarks accordingly. So we want to add hearing, vision, and dentistry, but we want to do it in a way that's not going to wind up double paying the MA corporations to do it. And of course, we want to add in a pharmacy benefit into traditional Medicare, again, to do that carefully for the same reason. So we think those benefits that are within Medicare Advantage are really not that generous, as you've seen me talk about, I think. But they need to be at least at the level to give people who are in Medicare Advantage parity, should their Medicare Advantage companies not be there. So improve traditional Medicare in those ways. And then also we think it's really critical to introduce long-term care as a part of traditional Medicare. So that's our triple aim writ large. We want to get to single payer. We think we want to get to that by ending profiteering and by improving traditional Medicare. We believe both of those things drive us towards single payer. We think both of those things, Medicare Advantage is a barrier to getting to single payer, and improving traditional Medicare in the ways we just described facilitates single payer. It's sort of stuff you have to do to get to single payer. But there is a barrier between here and there. We can't just cross that brick wall. And the way to get there organizationally is we need to build power. PNHP has to be a lot more powerful than we are today if we want to actually cross that brick wall. So that means we have to be bigger. We have, what, 26,000 or so members, physicians in PNHP, and students in PNHP, and there's, what, like 1 million physicians in the country. We've got to do a lot better than that. We need a lot more than 26,000 members. Imagine if we went to Congress and said we represent 200,000 doctors or 500,000 doctors. We would be a lot more powerful in Congress. So one of our core strategies to get more powerful is to grow the organization, and we have a lot of pieces to making that possible. We need more money. It's ridiculous that we have a staff of 4 or 5, today, because that's all we can afford. that's crazy. So, but staff cost money. They are our biggest expense, and they are also our biggest return. So you'll see lots of fundraising around PNHP, and indeed, we think we're going to be able to hire up to 6 staff. We're going to have a staff of 6 in a few months. So hooray for that. Thanks to all the work we're doing on that. And then grants. We've never taken grants before, but we're going to talk a little bit about the grants that we've gotten. So we're pursuing more. So that builds our power. We also want to have stronger and more diverse relationships with members of Congress. So we have strategies to do that, makes us more powerful. And then lastly, be more thoughtful and aggressive about collaborating with our allies in other advocacy organizations. So that's what we're doing. So this sort of strategy, this triple aim, has let us work with groups that we've not been able to work with before, which again builds us power. So ending profiteering as a goal in and of itself. If we focus just on that, just on ending profiteering, that's got really broad political appeal, much broader than single payer by itself does. So we've been able to have allies that we didn't have before. A great example of that is I was speaking to one of our allied organizations about our approach, and Arnold Ventures came up to me afterwards and said, "Hey, we really like what you're doing, and we'd like to figure out how to work with you on that." Arnold Ventures is a group that's been funding quite a bit of progressive research and advocacy work in the last few years. They they have funded some of our Medicare Advantage work and some of our Medicaid work now. So, hooray for that. They are not a single payer centric organization. As a matter of fact, I don't think they think single payer is the way to go in the future. They're very pro competition. Their origin story is from the oil industry, frankly. So, unexpected bedfellow, but they have been a spectacular allied organization to be working with, and indeed, as I've said, they've been funding stuff. So our focus on ending profiteering has created new allies, new opportunities, and getting us into conversations on a bipartisan way in Congress. So hooray for that. But not all of them agree with any of the rest of the stuff we're talking about. Not everybody who agrees that we should end profiteering thinks we should do it as a way to improve traditional Medicare. And in fact, some of the groups, some of the members of Congress who agree with us about the hazards and the harms of profiteering, we think that money should be redeployed into improving traditional Medicare. Not everybody agrees with that. Some people think, well, we should end the profiteering so that we can deal with budget deficit issues, or that we can deal with the reconciliation bill, or that we can, just focus that profiteering money, redeploy that onto improving the physician fee schedule into traditional Medicare. So not everybody who agrees with us about ending profiteering thinks that money should be redeployed into improving traditional Medicare. And we will walk with them on the ending profiteering piece, and then divorce, we'll part ways when we talk about improving traditional Medicare. And that's terrific that we're able to do that. So yeah, we think we need to improve traditional Medicare, and we think we should do that as a way to build the foundation for single payer, because single payer, of course, is not Medicare today. It's improved Medicare. It's hearing, vision, dentistry, pharmacy, and all the other things that, you've heard us all talk about. So we think improving traditional Medicare is part of getting to single payer. There's a lot of folks out there who agree with us about ending profiteering and improving traditional Medicare who do not agree with us about that as a way, about wanting to do that because they want to get to single payer. And you know what? That's perfectly fine. So we've got these groups that we are now working with who agree with the outermost circle. That's the biggest group of allies. And then the next circle in to do that to improve traditional Medicare. And a smaller subset, actually a pretty good sized subset, but a smaller subset of those agree with us about all 3 legs of our triple aim. And that's where this has become so powerful, is because we've been able to work with groups. Our answer 5 years ago, if somebody said, what do you think about this healthcare policy position? We would look at that as an organization and go, well, that's not single payer. We don't support this. Well, you know what? If that's your approach, then they don't really need to ask us, because they already knew going in that it's not single payer. We think it's a good thing, but it's not single payer. So our migration from the litmus test of is it single payer into does it align with our goal of getting to single payer, even though it is not, that goal has greatly improved our credibility with media, our interest from granting organizations, and frankly, a lot of physicians and other groups. So it remains our true north, but we are willing to talk to folks about things where we do agree. They agree with us about cutting the profiteering and the privatization. Why in the world would we not work with them on the areas where we agree? That's new for our organization. You're all relatively new to this whole movement, so you may not recognize it, but that's a huge cultural shift from where we were up until about, let's say, 5 years ago. So, and we're in fact starting to talk about going further than that, that indeed single payer, our true north, the thing that we are, most intensely focused on all these years, um, is no longer really sufficient for getting to where we want to go. And we're going to come back to that in a moment. So we are, changing as an organization. Our strategy to get there has been sort of our typical strategy, which is let's expose things and then use that as the basis. So when we first started working on privatization and profiteering, 2.5 years ago or so, we produced this report looking at the overpayments to Medicare Advantage because we thought that would be enough. We saw the MedPAC reports that said that Medicare Advantage was being overpaid on the order of 80 to 85 billion dollars, on the order of 20% more than what they needed, than what traditional Medicare is paid. We saw that report. We saw these reports over the years saying 80 some billion dollars. And then you saw people in Congress, when we go to talk to them about the overpayments to Medicare Advantage, they would say, yeah, yeah, we know. It's all that upcoding for about 10 or 20 billion. So the MedPAC report was saying 80 billion, and members of Congress were only quoting, frankly, one of the smallest pieces of that, the upcoding at, let's say, $20 billion. And we thought, well, let's weigh in on this. Let's amplify this. So we did a deep dive. We looked at the MedPAC reports and at, frankly, dozens of other reports. And we came up with a much bigger number. We think it's more like $140 billion. And I think our coming up with that bigger number got people to start saying, well, 10 or 20 really isn't the story, so they moved over to. So now you're hearing most people quoting MedPAC's 80 to 85 billion dollar number, and I think we've done a lot to shift the narrative. So we went to Congress and said, 140 billion, and we think that helped. And but the response we got from Congress when we would meet with them about these big numbers of overpayments was, yeah, but Medicare Advantage is the solution to racial inequities. And so we don't really want to touch this. We thought, that can't be true. That just can't be true. And so we thought, well, the main reason we think that can't be true is because we're physicians. We think Medicare Advantage hurts people. So let's go back and show them that Medicare Advantage hurts people and therefore it can't be the solution. So we produced our second report called Taking Advantage, and that came out last year. And it unpacked, frankly, overwhelming literature showing that Medicare Advantage hurts people. And we've kind of walked through some of that with you previously. So we went back to Congress. We said, well, look, they're overpaid. And I know you mentioned that this was a solution to equity, but oh my God, look at the harm it's causing people. It can't, a solution that harms people can't be the solution to equity. And they said, well, thank you for this, but it's still what we're hearing is the solution to racial injustice. So, sorry, but no, we're not buying. Crap. Well, that's where we met Arnold Ventures, and they funded our new report about racial inequity and Medicare Advantage. And we are going to be, we're nearly done with that. I was just meeting actually with the Johns Hopkins researchers that are doing some of the work for us, subcontracted with some of the work on this. And we're going to be doing focus groups actually next weekend. So it's nearly done. This is, and we've decided to paint this as a narrative about Medicare Advantage as a piece of, frankly, racism over the course of hundreds of years in the country. And we're going to show how this fits into that. And we're going to show the role of Medicare Advantage within that. Anyway, that's on track for release late August or early September. And then with hopefully a couple of dozen of briefings of different congressional groups and others. So that's afoot. We're hoping that that's going to finally get the ball over the finish line. But it'll move, but it's not not everything, and it's not going to be everything. And then we have other things. We are focused on Medicaid deprivatization. Um, so we think the time is ripe for that discussion. The majority of Medicaid members in the country today are in commercial HMO type plans by commercial insurance companies. The majority are no longer in a state-run program. And we believe that the reason that they're in these commercial insurance companies is because of ideology that, oh, privatization is good, managed care is good, and all sorts of related things, and some corruption, some various issues. But we think that the preliminary data from this study that we've been doing is going to suggest a double-digit number, I think, that states are overpaying to have Medicaid privatized, and that they could save a meaningful percentage of what they're spending on Medicaid today if they were to go back to the deprivatized form with some improvements that we're going to spell out. So we think that that's an opportunity, and we think the timing for this is really critical because, as you know, um, there's a double-digit cut to Medicaid funding to the states. It's been part of the reconciliation bill, and we don't think there's enough money for deprivatizing to reclaim all of that. But we do think that a state that doesn't want to so profoundly damage their Medicaid program is looking for ways to preserve some of the funding. We're going to make the argument in the fall that deprivatizing is a way that they can reclaim some of the money without having that they can deal with the shorter budget that the feds are imposing without having to be as egregious as they would otherwise have to be to their program or raise their own taxes as much. So, at any rate, that's we're on track to have that report produced by the end of the summer. And we're hoping that some Harvard attorneys will be able to write model legislation that we can be providing states as a way to move forward with this. And it's pretty exciting. We have some allies. One of our ally organizations, actually, People's Action, is the group that asked us to do this work. And so now we're working with People's Action and National Nurses United and a few other groups to complete this report and this model legislation. And we're hoping to have that done in time for it to be usable by state legislatures and advocates this fall. So that'll be our fourth report. And then, as I think you've heard about, our moral injury work funded also with a grant from the Robert Wood Johnson Foundation, looking at how financialization writ large is really destructive to healthcare providers. And that'll be coming out. We'll be talking about it at the annual meeting in November, and the report should be out hopefully by December, at least a preliminary form of it. So that's kind of the story of our core stuff. The reports that we've produced in the past, or the PNHP leadership members have produced in the past, have not been linked to advocacy work, and nearly as clearly. And each one of these things is linked to direct advocacy work. So the landscape is changing since when we were formed in 1987, and indeed the last, year, frankly. We've seen a dramatic shift, which I'm not going to belabor with you, but all four, both the House, the Senate, the executive branch, and indeed the legislature are not as friendly to the stuff we want to do as they once were. So we're having to adapt to that. We're hoping that won't always be the case. But we're a C3, not a C4, so we have to be thoughtful of how we approach that. But it's a different landscape than it was. The budget reconciliation bill is what's up, or law is what's creating the key fight over Medicaid right now and how to protect it. And other things. We're seeing a rapid growth in attacks on reproductive justice, which, the single payer bill has always been pretty clear that that it protects that and expands on that. But we're getting increasingly explicit about Medicare for All, reversing the Hyde Amendment basically and making the Hyde Amendment not apply. So those of you who are focused on reproductive justice, as I am, are glad to see that getting even stronger. And I don't know if you've been paying attention to this, but the Supreme Court made a decision that's called the Chevron decision, that sort of undoes the ability of regulatory agencies to really define what's in what's meant by legislation. So most legislation today, and indeed Medicare's laws, and indeed the single payer bills that we're proposing, delegates a whole lot of the legislation's implementation to the regulatory process and to the regulators. And we talked a bit about that, how important that was a few days ago, how important it is to pay attention. But the Chevron decision is a decision that the Supreme Court made that is thought to really curtail how much the regulatory bodies can do interpreting the statutory piece. And so we are thinking about when the Medicare for All legislation gets resubmitted in 2027, I guess it will be, I don't know, because we just, it just came in. So yeah, in 2027 for the next cycle, that it needs to have more protection from this change in the power of the regulators. So there's plenty of places in the bills that specifically empower the Secretary of HHS to make decisions about how Medicare for All would be implemented. And I'm not impressed with RFK Jr. as the Secretary of Health and Human Services being the person that would make some of those delegated decisions. So chances are the next iteration of our bills will have to respect that and come up with an alternative that's not quite as delegated to the regulators. And then the other piece of the landscape that's changed profoundly from the foundation of PNHP is that, most, I think it's something, I don't have the numbers, so I'm not going to quote you, but clearly a majority of physicians these days are employed rather than being independent. United Healthcare itself is the single largest employer of physicians in the country. There's more than 90,000 physicians who are employed directly by United, not just like on contract in their network, but are actually employed by United. And so that changes a lot of things. It changes the opportunity for unionization, perhaps. It changes the ability of physicians to be outspoken when United. I don't know if you saw the New York Times. Today's Monday. Yeah, yesterday, the front page of the New York Times, literally above the fold. Those who follow media talk about it being above the fold. If you get a newspaper, it's typically folded in half, and the story that's above the fold on the front page is considered the premier landscape. Above the fold on the front page of the Sunday, the premier edition of New York Times was exposing how United Healthcare attacks physicians who raise their voice. So, go back and have a look at New York Times from yesterday in case you missed it. So anyway, the landscape of what it means to be a physician who wants to be an advocate has been shifting quite a bit, and PNHP really needs to adapt to that. So that means that this foundational document that I mentioned that really kind of was the first organizing tool for PNHP in 1987 or whenever that was. And we've updated it every 5 or 10 years. So the one that's current is not the same as it was, but the main updates in the last iteration were to address some stuff in the ACA, but we need to really have a much different vision. Still single payer, absolutely still that, but it needs to address a lot more. All the stuff on the left side of this chart needs to be embedded in the physician proposal. And should it even be called a physician's proposal, which is the historic name? I don't know. So there's a multidisciplinary, I think you could say, task force within PNHP and beyond with some allies starting to form to look at what does this look like. We need to certainly update it to deal with the things on the left. We need to probably reformulate it, broaden the vision so that it's more clear about some things and deals some of the issues that privatization and employment have introduced. So we need to broaden, and we are broadening our profiteering targets. We spent, 2 or 3 years talking almost exclusively about Medicare Advantage, and we need to continue that. We should not lean up on that at all. But, we are now embracing a discussion and activism around Medicaid privatization, and around the role of venture capital and private equity and financialization writ large. So we are broadening our profiteering targets, and the Medicaid work has been developing on its own as a siloed part within PNHP almost. And so we're recognizing how powerful and important that is. And we've actually built now a coordinating committee to coordinate the work between Medicare for All and Medicare Advantage and Medicaid, because there's a whole lot of synergies in this work that we've been casually reaping the benefits of that we need to be more thoughtful about. So we're more thoughtful about being coordinated amongst these different campaigns. We're more thoughtful about how important it is to have this chapter structure. That's something that sends PNHP apart from a lot of other organizations. So we have a presence in so many states. We need to really strengthen that. It's a really good way forward. They've been getting much more influential. And SNAP, and we're going to come back to that, but the importance of having this student arm that's just we're going to come back to that. But these are some of the things that we're planning on evolving as an organization. So we need obviously to focus on physicians. We are Physicians for National Health Program, and physicians are most easily persuaded with science and policy and narratives. And so we're continuing to, build those things out, for obvious reasons. The reports I mentioned are very heavily sciency and with links to policy and always embed narratives. For the reason of becoming a more advocacy related organization, we've been aggressively organizing our approach to medical societies, finding we have more allies within there than we had really taken advantage of. We have been training physicians and students on how to meet with members of Congress. So we had our first sort of aggressive approach to that this year, and we've been discovering that that really is paying off because the meetings have been successful, and because now the people who were trained on that have been trained as trainers, and they're often able to go further. So we can train physicians on how to meet with members of Congress without having to exhaust our remarkably limited staff resources. So this is continuing to move forward. The student arm is incredibly important for a number of reasons to us as an organization. The first is, long term, we want students to be embedding activism as a part of your core identity as physicians. When you learn to be activists when you're students, then you can feel its absence if you don't think you have time to do it as a resident or in practice. So we want it to become sort of part of your core identity. So taking a role in this. So students have tremendous value, which we've talked about previously. But also, I sort of think of the student investment as our version of the Federalist Society's campaign. The Federalist Society, 40, 50 years ago, invested in law schools. They created a strong presence in law schools and dramatically changed the curriculum in law schools and got a good presence there. And now they're part and parcel of where a lot of attorneys think and go to for opinions. Um, that's kind of how we're viewing SNAP, is we view them, we view y'all as really important. So it pays off. There are legislators who have had former SNAP members as legislative aides, and it's really important. And then, sort of from a PNHP selfish point of view, students bring all kinds of ideas that we old geezered, wizened attendings don't necessarily think of. So it's fantastic getting these ideas that you all bring up at our meetings and in our committees, and it's really important having these ideas that you all bring up. And then chapters are incredibly important. It's a great way for somebody to get engaged with the organization. It's a great place in a small group to build your skills. Have a local impact is easier. It's a great way to meet with members of Congress. We talked about that in the past, so it's huge. And then some organization-wide activities. And then just lastly, we used to meet casually and informally with some of these groups, but for the last, I'd say, 2 years, because of our changed, evolving triple aim strategy, these are our allies now. We meet with this collection of groups literally every 2 weeks. Literally every 2 weeks for the last 2 years, we've been meeting with them every 2 weeks. I go to the meeting. There's usually 3 or 4 people from PNHP staff at the meeting. So, we're doing this. We are working with our allies more than we ever used to. So that's that's where we are. That's kind of our nickel tour on our approach. And I think we're out of time, unless you got we've got a few. I've got a couple more minutes if you all. Have questions or thoughts?
Yeah, thanks. That was a really great overarching summary. 'Cause I've plugged into PNHP at different moments and learned about what's currently going on, saw a lot about the moral injury research that's coming out of the project, but I didn't understand this baseline, how it fits into all the campaigns. I was wondering if there's a change in how to get more physicians involved, particularly like regarding these, you mentioned the New York Times article yesterday, how it like personally, the financialization and profiteering really has a bad personal impact on physicians, um, and what we can do at work and moral injury. Yeah, how is reaching out to new members and like developing new members changed in the past few years?
Yeah, I don't think we've come up with the silver bullet for how to do this, and it aggravates me because there's what like 1 million doctors, and we believe surveys show that there's 60% support for our position. So we should be 600,000 members strong, and we're not. We're 25,000 members strong. So there's a huge opportunity to get further. And I don't think we ever were really all that thoughtful about it in the past. And so now we have a few campaigns targeting that. They're going to take time to build, but the moral injury report was sort of one of our first salvos into that because we think and it's working. You know, we're getting a lot of new physicians interested in engaging with PNHP. We're getting new PNHP members through that. It's a way to get people's attention. It resonates with people who don't think about advocacy or think about single payer at all. And once you commit to saying, this is really hurting me, it's not a very far leap to go, yeah, it's you're not burnt out. It's the system that's hurting you. And over here, we're the group that's trying to fix that, and we need your help to fix. So the moral injury report is number one, we want to do the report because I think it's important information to collect. But number two, it's strategically important because it's helping us do just what you're saying. And we think when it's published, it's gonna hopefully take off dramatically even more connection because the campaign's not going to stop when it gets published. I think that's going to get it in front of more people than we've been able to do. So that's that's a several year strategy to get into more heads. The medical society piece is also much more robust. Our approach to medical societies in the past has been if somebody in PNHP was interested in going to meet with a medical society, we would encourage them to go do that. But in the last couple of years, we've done something different. We've looked at what are all the medical societies, who are the most influential, where do we have a presence that we could foster? What does it cost to go to the meeting? What does it cost to get here? What does their member interest group structure look like? How do we get one of those started? So we've actually come up with 10, I think it is, medical societies that PNHP has identified as the best targets, both between potential influence and realistically, can we make a difference there? And then we've looked at, well, what does it cost to go to their annual meeting? What does it cost to do this? And what are our resources? How many of these can we do? And so we've been organizing that, and we've been, then okay, we decided on this specialty is an important one. Let's reach out to all of our members who are in that specialty and see who's going to the meeting and encourage them to go to the meeting and encourage them to do this. So we've been more thoughtful about that. We've been writing, many of these societies have been looking at single payer resolutions. And we realize that that's marginal, that's a hard, heavy lift. So instead, we're looking at the medical society resolutions in alignment with our triple aim. It's really hard to get a pro single payer resolution passed by a medical society. But if we believe, and we do, that impacting the business model of Medicare Advantage is part of the road to getting to single payer, well, then a medical society a resolution that exposes and calls for a change in the business model to Medicare Advantage is a less heavy lift and is a tangible step towards achieving single payer. So the medical society resolutions are being proposed in ways that align with achievability and matching with our triple aim. Um, so there's a bunch of things like that, but none of these are this. It's complex, so it needs a complex solution. But a lot of them are going to take a few years to pay off. You don't get a resolution past the first year you submit it. So that's these things, you know, it's afoot. And it wasn't afoot 5 years ago. So it's exciting.
Yeah, I actually met Rebecca at the preventive medicine um, annual conference because she was there for PNHP. And I was like, that's great. Um, yeah, I've been doing some organizing with the Vermont Workers Center, which is like a people-powered grassroots organization that their big campaign is healthcare as a human right. They're part of a more widespread state-based nonviolent Medicaid army, and their one of their number one tools is like reaching out to people, meeting people like across party lines where they're at and saying, hey, we all have a problem with getting healthcare, and like, do you want to join us? And so I just like think a lot about their strategy, and they like pull on like a lot of historical movements, and I'm planning on actually talking with you guys about something like that. So it's like really helpful to hear that that's something PNHP is looking to do more of.
Absolutely. And
Yeah.
we're really thought, I mean, 5 years ago, we kind of acted and thought almost as if we were the only voice in town. And we thought, we have to do everything. If we wanted
Mm.
public education, we thought, well, we've got to do that. We've got to do this. We've got to do. And we're realizing like that big list of organizations that I showed you, we all bring different skills to this fight. And there are groups on there who are very connected with communities. There are groups on there who, well, like People's Action asked PNHP to produce a scientific, or an evidence-based report about Medicaid privatization, because we have more of those skills than they do. But the campaign to use that report, we're going to use it, in the ways that we do. They're going to use it in the ways that they do, and that's the power of, we no longer think of ourselves as the only voice in town. We're not even the group that convened all those allies. Be a Hero convened them, and we're been a part of that, and we've been incredibly active participants. But and now the Center for Healthcare, Health and Democracy, Wendell Potter's group with Rachel Madley, is now chairing that group of organizations together every 2 weeks. And just to give a nice shout out to Rachel Madley, who was Representative Jayapal's staffer and is now, one of the key people working at Wendell Potter's Center for Health and Democracy. She was one of the first SNAP students. So SNAP is working. And I've got about a minute, and then I'm going to have to run off to get ready for my thing that I have the next hour. And I think I'm your last one, so you can stay another couple of minutes if you want to. But any other questions or thoughts or comments before I run off until I see you again tomorrow to talk about the public option? Well, let me give you a sneak preview. Tomorrow's discussion on the public option. It's a topic that's near and dear to me. I happen to think that the road to single payer goes through the public option. But to be clear, that's a minority view. PNHP does not, PNHP as an organization does not agree with me about that. So I will present what I hope is a balanced perspective on it. So I'll tell you why I think it's a good idea. I'll tell you why it's not a good idea. I'll tell you what the risks and hazards and benefits are. And yeah, I think it'll be interesting. And then I'm going to ask your opinion at the end of that. So anyway, I'm going to run, and I'll see you all. Nice to meet you, Eve, and I'll see you folks tomorrow.
Good to meet you. Thanks for having me.
Thank you.
Yeah.
See you guys.